We'll just yeah, give it 1 minute past. Okay. So we'll make a start then, and just for everybody's information, this meeting is being recorded, so it'll be available to those who can't attend. So I'd like to welcome everybody to the July Cancer webinar, and really pleased to be able to introduce David Holland, who's works at Norfolk and Norwich, who's going to talk to us about palliative care, and is happy to be interrupted and take questions as we go along or at the end. So over to you, David. Thank you.
Thank you. So yeah, absolutely. Please do interrupt if you got any questions. Sometimes when we're sharing the slides, it's difficult for me to see, so just shout out. I'm going to try and share the slides from my side. So can you guys? Can you guys see that?
We can.
Yes, we can see it.
Oh, perfect. Fantastic. So I was asked today to talk to you about early palliative care and introducing palliative care as a topic to patients. I'm, as Nick was saying, I'm one of the consultants. I work both here in the Norfolk and Norwich, but also in Priscilla Bacon Lodge, which is the local palliative care unit. And I was asked to talk about the early palliative pathway, the beginning of palliative care, how to have difficult conversations, understanding what's available in respect to the services, and discussing having early conversations about palliative care. And I was asked to do that in about 40 minutes, so that's quite a lot to cover. So I hope I've managed to go through it. But do stop me if I'm rushing through things or things are unclear. And because there were a few topics there, I've changed the structure a little bit, and I was going to talk about a very brief history of palliative care. So why the services are a bit like they are today, the current structures, so what's on offer to your patients, when and how to refer, and the referrals that we will accept, and a little bit at the end about how to introduce the subject of a palliative care referral to your patients. So as you guys are probably aware, palliative care is quite a young specialty, and it came about mostly from the 1960s onwards. Does anyone know who this is, out of interest?
Looks a bit like Mary Whitehouse, but I know it isn't.
It does. So this is Dame Cecily Saunders. So she is famous for being the first person to create a model of care for the terminally ill patient, which was based through hospice care in the UK. And she's got an institute named after her, the Cecily Saunders Institute, which is run by King's. And then, so she introduced the concept of having this model for the terminally ill. And then in the 1970s, there was a gentleman called Balfour Mount who termed palliative care as a phrase. And he had started the first palliative care unit in an acute academic hospital in Montreal. And since then, the specialty's been evolving. So from the 1990s, it became much more common for people to be seen in outpatient clinics for palliative care. And since the 2000s and onwards, and particularly since 2010, there's been increasing evidence for palliative care. So some of you might be aware that there was this paper by Jennifer Temmel that looked at randomizing people for earlier palliative care versus not for patients with metastatic non-small cell lung cancer. And the outcome of that trial was a bit of a keystone trial for our specialty, because it showed that if the patients got early palliative care, then they had better symptom control, but also actually it improved their prognosis and their longevity. So that was the first sort of big bit of evidence for palliative care. And since then, there's even been a Cochrane review showing that there is evidence for early palliative care in people with advanced cancer. And the way that palliative care looks at the moment is changing considerably, partly because of the pressures on service, which I'm sure everyone here will be aware of, and because of the aging population, but also because of the novel therapeutics which are coming into the treatments that people are that are available to people, which blurs the line of when someone would have typically been referred to palliative care. So an example of that might be the treatment of oligometastatic disease. So previously, where people were, if they had metastatic disease despite chemotherapy, were usually then considered palliative. Now there's some patients who aren't. So that line is now blurring about where we come in. And traditionally, if you look at the top bar here, the traditional concept of palliative care would have been that people would be treated by their team, say an oncology team, until it got to a point where there was no further treatment that that team could offer, and it was felt that the patient might have a poor prognosis, and then they were referred to palliative care, and the care sort of switched over from their treating team to the palliative care team. And as time has gone on, that concept of palliative care has changed somewhat. So the emerging concept of palliative care was that, and what is starting to happen is that people get referred early on when they have a diagnosis of a life-limiting illness. And palliative care will initially have quite a small input, maybe even just an introductory to the team. But as things change and the patients become less well, the input from the palliative care team would increase up, and the team that were looking after them would decrease down, and until eventually most of the care would come from palliative care. And then also, as things have progressed, palliative care have had more of a role in bereavement as well. And in fact, I think this is even changing now, so that our input is more a bit like this. So occasionally we'll get called to see patients for symptom control where they're still quite early on in the disease, or they're having treatment-related symptoms, and we'll have a little blip where we'll see them, and then we may discharge them from the caseload, and then those blips might happen again, and then it might be that we then continue to have them on our caseload, and our the amount that we'll see them will build up. Did I see there was a hand up?
Yeah, Ian's got his hand up.
Sorry, yeah, just you did say interrupt. I was just thinking, sort of, on that that spectrum, sort of, one of the things I think about was patients who might get spinal cord compression, where actually, so we know that rapid treatment can actually make a good sort of a difference to their outcome or quality of life. Would that come under you? Would it, is that a kind of grey area, or would that go to kind of traditional oncologists? It's just really understanding that spectrum of who would pick things up.
Yes, absolutely. So the treatment of a spinal cord compression would be the oncologists who would do the treatment for it usually. So if we suspected one of our patients had spinal cord compression, we'd be referring to AOS to see them. We'd probably start the steroids, refer them to AOS for an emergency MRI scan, and then they would initiate the treatment in terms of radiotherapy or rarely surgery. But then we would obviously, after that treatment has been done, where they're trying to preserve the neurological function, we would then help with managing symptoms after that and supporting the patient. Does that answer your question, Nick?
Yeah, thank you. Yes, that's very useful.
So there's four main services that palliative care tend to provide, broadly speaking. So there's outpatient palliative care clinics, which can happen both in the hospital, but also in the community. So for example, we run clinics out of the Norfolk and Norwich, but also have them running out of Priscilla Bacon Lodge. There's inpatient palliative care consultations in the hospital. There's community-based palliative care, which is mostly run by clinical nurse specialists, but also there's medical team input, both from consultants and specialty doctors and registrars from Priscilla Bacon Lodge. And then there's the hospice or specialist palliative care unit, so that would be Priscilla Bacon Lodge. And then the other main big service, which you guys would be aware, is the generalist palliative care, which you guys provide. And a patient will typically encounter quite a few of those services that I've just talked about. So for example, when a patient's first diagnosed with an advanced disease, they put cancer here, but it could be any disease with a which is non-curable. They would typically see their home team for a while, and then they would be referred to us if they developed symptoms or needed extra input, and that would usually be as an outpatient clinic out of the hospital, or as I say, in the community. And then it might be as things progress, patients get acute deteriorations where they get admitted to the hospital. And if these happen more frequently, then they might be seen by our inpatient palliative care team. And if we find that they're deteriorating and having lots more admissions, then it's likely that they'll need increased input, and then will be followed up by more closely by the community-based palliative care team. So that would be a CNS who would have more regular contact. And it might be that they continue to need inpatient reviews, and they might continue to see people in outpatients from the medical point of view. And as things change, it might be that they then need more intensive symptom control or end-of-life care, and then they might end up using the inpatient units or hospice care. So you can see how a patient might go through all 4 of the strands that I mentioned before. And another newish idea that's come that you might have heard about or you might have seen is this idea of supportive care versus palliative care. And I just wanted to see whether you guys had heard about that, or what exposure you'd had to that term supportive care and what it means to you guys.
I suppose I tend to think it's best supportive care, kind of trying to and almost sort of an intermediate between that and palliative care, which sounds a bit sort of terminal. So kind of so maybe supportive care is slightly wider, going out slightly longer.
Yeah, absolutely. So one of the things is that the terms often get used interchangeably, but there's this idea, as you say, Nick, that supportive care is something to do with supporting symptoms but not necessarily that end of life type component to it. And as you say, supportive care, some teams from which are palliative care teams are often rephrase their name as supportive or enhancive care. And there is a slight difference in the terms. So supportive care is the idea of prevention and management of adverse effects of cancer or other diseases and its treatments, which includes management of physical or psychological symptoms and the side effects across the continuum of their experience from diagnosis through treatment and post-treatment care. So the idea being enhancing their rehabilitation, preventing further deteriorations, particularly in cancer, survivorship and end-of-life care are part of supportive care, whereas palliative care has a slightly different definition, where it's defined by the WHO as improving quality of life of patients and family facing the problems associated with life-limiting illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, be these physical, psychosocial or spiritual. So you can see that there's considerable overlap between the two terms, but they are slightly different. And you can argue that this little graph that I've created, which isn't quite as neat as the ones from the paper, show that those little blips, you could argue, are what we're doing as part of supportive care, and it's becoming slightly more a part of our role. Sorry, there's a hand up again.
Yeah, just me with the hand up. It's Vicky. I mean, these pathways look very personalised already, but I wonder if you have specialist input for people with LD and autism, for example, or for other people for whom we normally with our pathways we'd say reasonable adjustments. But how you support those patient groups, because we're currently looking at our pathways as a whole for cancer and where people are disadvantaged, and how you address that as a service. Like I said, it sounds like you're very personalised anyway, as you have to be, don't you? Because everybody's kind of different, but it's just I can imagine that for maybe somebody with autism, for example, that it could be quite distressing, especially if you're not if you haven't been treated outside of your home or whatever you've been used to before.
Yeah, absolutely. So as far as I know, there isn't a defined pathway for that, but the way that we tackle it, Vicky, is by, as you say, having a really personalised, tailored service. So often we've got the ability, fortunately, through the wider team working, to be visiting people at home. Often we'll do joint reviews with, if someone had learning difficulties with their support team, for instance, and we tend to just personalize it that way. So often we'll do joint reviews with other teams, we'll do the reviews in the preferred setting of the patient. Often we try to be a bit of a focus to work the MDT around our care if we're then becoming the main providers, but kind of be a hub for all of it. So it's more doing it per patient. I don't think there's a specific pathway that I'm aware of.
Thank you.
Thank you, Vicky. That's a really good question. I wanted to talk a little bit about specifically the community services that are available in Norfolk and the ones that you guys will be referring to as well. And I've already mentioned some of them a bit. So there's the community team, there's the inpatient palliative care unit at Priscilla Bacon Lodge, there's our Rowan Day unit, and then there's the medical outpatient services. And we're really lucky in that we have a very wide MDT, and this might answer some of your question actually, Nikki. In that we have, Vicky, so in that we have nursing staff, both clinical nurse specialists, some of which are prescribers, and inpatient nursing staff. We've got physiotherapists and occupational therapists. We've got a pathway facilitator who works mostly out of Priscilla Bacon Lodge. We have chaplaincy support, and we also have a fantastic psychological support team, which includes child and family support where needed. We've got a medical team, so we've got team medical professionals across, which is a mixture of consultants, specialty doctors, and some junior staff. So we have IMT and GP trainees. We've got a fantastic admin support. We've got a nurse consultant who works out of the day unit. And then we've got complementary therapy, which is hugely appreciated by the patients, and a volunteer service, which I'll talk a little bit about in a minute. And just so you know a little bit more about those, so the Rowan Day unit is attached to Priscilla Bacon Lodge. It's at the other end of the building to the inpatient unit. And what tends to happen is they run groups out of the day unit, which usually last a morning or an afternoon, and the groups tend to go on for a period of weeks at a time. And there's various groups. So there's the breathlessness group, where patients learn to cover skills and strategies which will help manage breathlessness. There's arts and crafts groups, which again help to develop creativity and help to support legacy work for the patients. There's a creative living group, which helps people through different themes like art and music and nature, to provide a confidential space to share experiences of living with life-limiting illness. There's an exercise group, which again helps people to self-manage their mobility and strength and balance. There's a room to relax group, which is for help with relaxation through things like mindfulness, complementary therapy, learning techniques to help manage fears and symptoms, and also addresses some spiritual concerns. And then there's a volunteer-led check-in and chat group, which provides a bit of regular contact for social interaction and refreshment. And also within the day unit, they do things like providing infusions and transfusions. So the predominant ones that people would have are things like bisphosphonates or iron infusions, blood transfusions. And also because we've got a nurse consultant there and the medical team, if someone comes to a group and are less well, we can do sort of ad hoc reviews of those patients if needed. So at the other end of the building, there's the inpatient unit, which is a 16-bedded unit. People often think that they're all side rooms, which they're not. So there's 4 side rooms available and then 4 bays, which tend to be 3 or 4 patients at a time. And it's for patients with complex, severe and uncontrolled physical or psychological symptoms, which require our MDT input and which can't be adequately managed where they work currently. So be that at home or a nursing home or wherever that might be. And the main categories for admission are symptom control, so any symptom that's poorly controlled, and that might include pre-planned interventions such as blood transfusions. Terminal care, so if someone's preferred place of death is the hospice or Priscilla Bacon Lodge, then we try and get them in where possible. Where there's a waiting list, it tends to be those with the more complex needs who come in first. And then occasionally we have rehabilitation beds, but that's usually for a short period of usually 1 to 2 weeks, with the idea of trying to maximize people's potential in that time. And while I'm talking about PBL, I thought I'd give a chance to plug the new PBL, which I think is still being planned to be opened in mid-September, and is based just across the way from the Norfolk and Norwich here, just across the road, and we're all very much looking forward to.
Just to say, I think I spoke to somebody recently who was afraid of going to see sort of going to hospices and what have you, as part of the work she was doing. But
Yeah,
actually, when she went there, found it quite an uplifting experience. I think it's where people go to live, isn't it? Not where people go to die necessarily. So it's not all doom and gloom. I suppose that's what I'm trying to say, isn't it? It's
no, absolutely.
Mm.
Yeah, yeah. So I think what our role is trying to help people to live as well as they can in the time that they have left. And the hospice often is one of those places where it's a bit less hospital-like, and you're trying to, is trying to achieve the things that matter to the patients. And because of that, it can often be quite an uplifting place. It can also, because of the other side of it, sometimes, because people do. So we say about 50% of the people come for symptom control, 50 with the idea of them leaving. 50% of the people will come in for end of life, roughly speaking. So yes, but it is often, that's the experience, the sort of feedback we get from people coming to do placements or from working in there on rotations with the doctors, that they are surprised by the experience they have there.
Ian's got his hand up as well.
Yes, Ian.
Unless Ian has frozen, which is par for the course, unfortunately.
Oh, is it?
Oh no,
Sorry.
here he is.
He's back.
Yeah. Sorry, yeah, slight dodgy line. I guess you'll be coming to this, but sort of, obviously going to hospice, there's a clue in for the patient. One of the difficulties sometimes is patients, nobody's had that conversation that sort of, actually they're heading to the palliative care, and as you say in the paper, good evidence that early sort of input and understanding and allows people to make plans. It often feels like we've missed the boat, and we're playing catch up, and as you say, sort of the kind of trying to scramble in sort of symptom controls poor, and we're trying to get people in, so it sometimes can be quite chaotic. So there's sort of the real world, and then how ideally we'd all like our kind of our journey to be. It's how we can do better, really.
Yeah, and I think often it's about explaining. So I had this conversation actually yesterday with the patient, and it's about explaining the role of palliative care, and that it's not what people typically think, as you say, that it's just about you come into the hospice, it's a one-way door and you don't come out again. It's about that there's a mixture of people who go there, and the role of palliative care is to support with symptoms as well as looking after people at the end of life. But a big part of our role is managing symptoms and planning before that, and about helping people to live well, as Vicky was mentioning. So I think it's about how you sell it, and there is a lot of stigma attached to it, unfortunately, still. But we'll talk about that in a little bit, a bit further on in the slides. So you guys are probably aware of this because I'm sure you'll have all had interaction with the service before, but in the community, which is mostly run by CNSs, it's divided broadly into regions. So we have a north team, a south team, a central team, and then there's a west team, which is run by Tapping House. And there is various, so when a referral is made, there's various levels of input that we give. Sometimes it's simple advice and information only, to a one-off visit where we put a plan in place and then sort of step away. Sometimes we go and there's a bit more contact, so we'll see people for a period of time, but with the idea that, again, we step away when things are a bit more managed. And then when things are really complex, we have more intensive contact where we will be helping the patient more intensively, probably for a prolonged period of time. But if things do settle, sometimes again we might potentially step back. And amongst the community service, as I say, it's run mostly by CNSs, but there are doctors who do go out and see people in their homes as well as part of what we do, along with the outpatient clinics where we often will see patients jointly with the CNSs as well. And we try to have a bit of consistency in the community where there's the same person looking after the patient where possible. The referral form, which again, I'm sure you're all very familiar with, but I just wanted to put it up here as part of the introduction, is looks like this, and it gets sent to the email address at the top, the spcreferrals@nchc.nhs.uk. And we ask you to sort of tell us what you're referring for. So is it for medical assessment? Is it for assessment by the nurses? Is it in the day? Do you want them to be in the day unit, in the community? If they're coming to the day unit, is it for one of the groups or an infusion? The psychological support service can be referred to as well, and also for admission to Priscilla Bacon Lodge. And then we ask you put a reasonably level of detail on the referral to help us with the initial triage. And what we try on the referral form on the back, we've got a when to refer section, which we try to cover when we feel it's appropriate for us to be seeing people. And in general, we'll accept anyone with any life-limiting illness at any time from diagnosis, and that's both for cancer and non-malignant disease. But where there is complexity, so whether they have poorly controlled symptoms such as pain, where initial symptom management has been tried, such as a first-line strong opioid, or movement up the WHO ladder, but it's been difficult to get on top of it, or another uncontrolled physical symptom where it's not being managed by simple first-line interventions. Any severe unrelated symptom we'd want referred if it can't be managed in the first 48 hours of starting treatment. Psychosocial distress from either the family or the patient, where again it can't be met by more simple input, and where there's additional need for support around decision making, such as things like artificial nutrition and hydration, and whether that should be withheld or withdrawn. Again, where there's complex advanced care planning, where there's extra concerns or difficulties or complexity, again, would be something we'd be very happy to be involved with. And where there's complications with the dying process, be those physical, psychological, social or spiritual, any of those aspects, we'd be very keen to be involved. And I think that's quite well summarized by this graph, where you guys manage a lot of the less complex management in the community in this kind of bigger box, but where there's increased complexity, we'd like to be involved and earlier on in the course, and often we'll be becoming increasingly involved as it gets closer to death and providing bereavement support. And the other big thing to say is that we have an advice line. It's now one number, which is this 0330 number at the top there. And there's, if you call that and press 1, there's telephone advice for health and social care professionals. And the second option, number 2, is for patients and carers. Is there any questions about any of that? Sorry, I've just rattled through a ton of services, and I'm a bit aware I haven't given you a chance to ask questions.
We haven't had any hands up, so I think what you're saying must be, sort of very well explained, quite frankly.
Or completely, overwhelmingly
No,
explained.
That's why we record it. Don't worry.
So the second part to it was how to introduce palliative care and difficult conversations. And in some ways, when I was thinking about how to write this, I was wondering who is the best person to explain this, because in some ways I don't often refer to myself, and you guys will be doing the majority of these conversations about introducing palliative care. So I thought I'd start by asking you why you guys find it difficult or different to introduce this idea of palliative care and referrals to palliative care.
Well, I suppose the thing is that actually it's about timing, isn't it? And communication, and has somebody else already done it? And we have people who've come home and you have a conversation and you suspect that sort of somebody must have had that conversation, but then as you go along you find out that maybe they haven't, or the patient's not been in the right frame of mind or receptive to what they've been told, and particularly if you if the discharge note might say one thing but the patient's perception is very different, and then you're in that position where you think that the patient knows what's going on, and you're kind of wondering why they're wondering whether, and the family wondering whether you're going to be admitted back to hospital for further treatment.
So there's that uncertainty about who knows what, and the kind of the risk of introducing an unknown concept. Does anyone else have any feelings about why they find it difficult or different?
Sally's got a hand up. Sally from Great Massingham.
Hi there, David. I think sometimes people are in denial and they're so overwhelmed when they have that conversation with a consultant at the hospital and their families that, although it is explained, I'm sure it doesn't sink in. And then I think sometimes maybe they've not seen their consultant but seen someone else, and someone else may have said something different to the consultant, so they then feel that there's a glimmer of hope and things are going to be different, and that they're going to, there's something magical that can be offered them that might change the whole scenario. So and there are sometimes just people who've put their head in the sand and don't want to sort of acknowledge that there is a problem, and it's quite tricky sort of broaching that conversation and sort of timing it, as Ian said.
Yeah. So is that idea of kind of unpicking what's already been done and the risk involved in that, and challenging what people might have already said.
It also sometimes that it's quite quick. I mean, just thinking of my own experience of that it went from 0 to 100 very, very quickly. So although lots of planning had been taking place in terms of funeral planning and things like that, when the actual end came, it came very, very quickly. So we didn't really have chance to think about that, if it makes any sense.
Yes, yeah. So it's trying to cover too much ground too quickly, and then in some ways you can put the best plans in place and it doesn't always come to what you hope it might be.
It just happens too quickly to follow through with the what you could have shoulda, woulda, coulda, but it was just too quick.
Yes.
It's no one's fault.
Thank you, Vicky. And then the other question I had for you guys, which is a bit cheating actually, was to ask if you had any ideas about how you've seen it done well, the introduction to a referral. And again, I say this because you guys are the experts. It's very rare that I have to say, have you thought about palliative care? And then I am palliative care, sort of referring to myself.
And I think sometimes it comes from the family and sort of discussions, or from the patient actually sort of they've actually planned things out, so they can actually introduce it, which kind of makes it a lot easier.
Yeah, so do they introduce it themselves in your experience, Ian? So they might say, can you refer me to palliative care?
Well, yeah, or the family sort of say, sort of their relative is sort of clearly struggling, and what about palliative care or hospices or whatever.
Yeah. Julie?
Well, I tend to introduce it as a concept before they actually need it. So talk about the community nurses, talk about Priscilla Bacon Lodge, outpatient clinics across at Cromer Hospital. So it's something they don't need, but when they do need it, it's not so scary because it's already been part of the conversations. So that seems to work.
Yeah, I think that's a really powerful strategy. In some, like sowing the seed of it, that at some point it might be helpful to be introduced to this team, and then gently sort of drip feeding the idea around what happens. Thank you, Julie. That's really helpful.
I think she's not here, but one of the things that our Dr. Susan says, Dr. Susan Phillips, is that sometimes when she's seen on the wards and she's got a badge that says palliative, what have you, that people are afraid of her almost, like that she should come with a black cloak and a scythe or something like that. And I think, as Julie says, that if you can introduce it as, actually, this isn't something to be afraid of. This is, we're looking, this is part of the pathway, but it's not, it's not doom and gloom once again.
Yeah.
Beforehand, so you're sort of prepared before. I think Ian's got his hand over his, he's either frozen or I've made a gaffe. But certainly she feels the perception of palliative care is scary, and people aren't, so she hides her badge so they can't see that.
Yes. You do sometimes get that, absolutely. Yeah, you do. I think that's happening less and less, but thank goodness. And more often than not, when you meet someone who's had experience of palliative care before, their experience tends to be positive. And then I think that has helped to break down those walls, because we're sort of more out there than we used to be. Yeah, thank you. That's a really helpful contribution. Was there anyone else who had any good strategies that they've seen or heard? That's okay, everyone's been quiet. So I was having a thought about how I would go about doing it. And as I say, it's not something that, so occasionally when we get referred people, they're sort of unaware of what our role is, or they're not expecting us, but for most times they're expecting to see us. So it's rare that I have to kind of introduce the concept from the very first time. But I was thinking, if I was going to introduce it, how would I go about it? And I was thinking, is it like Breaking Bad news, actually? And I wondered whether it was, and it's how much it's like Breaking Bad news is probably depends on a few factors. So it depends on what you're referring for. So we've just talked about the various groups, like the breathlessness clinic, for instance, which would feel less scary than being referred to, say, the hospice, which I think would trigger most people to have a slight reaction to. It probably also depends on the person and their understanding of their disease, depends on the relationship of the person to the person who's trying to bring up the term palliative care. And it also depends on the patient's understanding of palliative care. So sometimes patients have had a partner or another family member who's already been looked after by our team, and that makes things a lot easier usually, because they're sort of aware of what the role is. But ultimately, I thought, yes, probably it is like Breaking Bad news in a way, because it's accepting that things are changing, the fact that you're making the referral, even if it just means that a symptom is worse, that referral is linked to the fact that things might be getting worse from the underlying disease. And because of that, I think some of the best ways that I could think about going to introduce it would be in the format of Breaking Bad news. So you guys are probably familiar with some of these, but the ways I thought I would talk about it were the spikes mnemonic, the wish, worry, wonder mnemonic, and a narrative approach to talking about it. And then there's this idea of a stealth referral, which I wouldn't recommend, but I have occasionally seen done, where people sort of promise one thing about palliative care, and then the patient gets a bit of surprise when they appear. So these top three are what I thought I would talk about. So the spikes is quite a well-known way of dealing with Breaking Bad news, and it stands for setting, perception, invitation, knowledge, emotion, and summarizing. So the setting part is how you're going to the environment you're going to talk about it in. So it might be that you've got a trigger that you want to bring a patient into a scan result or something like that, or a deterioration in how they are, but you want to make sure that you're doing it in a quiet setting with the right people around them, so family members, support that they would want. And then once you've sort of set up for that, you want to check what the patient's perception of how things are. So what the patient and their family think is happening that's made this conversation happen. And then you want to offer an invitation about what they would like to know, which is to check how far they would want to know about what you're thinking. The next part is knowledge. So it's explaining the disease once you've checked how much they want to know, and what the care options are in a plain language. So for the patients being referred to us, it might be that you explain that you've noticed that things are changing, and that you're worried that it's not something that we will be able to fix, but it might be that we try to optimize the symptoms that it's causing and plan a little bit for the symptoms it might cause going forward. And then you want to respect and you also, as part of that knowledge, explaining what the palliative care team do. And then the next bit is emotion. So it's respecting the feelings of the patient to what you've just said and responding with empathy to any questions that they might have. And then at the end, often, because like breaking any news, patients often don't take all the information in, doing a summary and deciding jointly what the plan was going forward and making sure they're happy with that. And as part of that spiked approach, you can enmesh quite closely this idea of a narrative approach when you're kind of introducing the idea of that bad news that you're going to give. And the idea of the narrative approach is that you're going from the patient's understanding to our understanding in a way that doesn't harm the patient. So in a way that's small steps that they can get eventually to the point where you are. So an example might be if you've had a patient who comes into clinic who's represented by this person at the top of the cliff, who's thinking, I've had a scan and it's shown progression. This is probably not good, but I'm sure there'll be more treatment options. Whereas we might be these people at the bottom of the cliff thinking, I could have told you things have progressed. She looks awful. I think she might be dying. And it's how we go about bridging that gap. So the risk is that you might then have a conversation that goes something like this, where the doctor says, how are you feeling? And the patient says, I've not been feeling very well recently. And then the doctor follows on with, I'm sorry that your news from the oncologist wasn't good. I think it's time to refer you to palliative care. And of course, what's going to happen if you say something like that, and there's such a big gap between the two people, is this poor person is then going to psychologically fall off the cliff and cause themselves an injury. And that might lead to breakdown in the relationship, or it might cause the patient lots of anxiety. And so I thought it'd be helpful to have a closer look at the idea of bridging that knowledge and how the narrative approach might be used. So if we're thinking about our cliff and the top person is our patient's understanding and we're this person down here in our understanding, I thought it would be, so in our original example, we've got the patient thinking, I'm feeling less well, but things will get better. And we're thinking they've advanced disease and I think they're rapidly deteriorating. If we then introduce the idea too quickly, we're saying we need to refer to palliative care. Of course, what's going to happen then, as I said, is the whole patient's going to fall, and it's going to cause injury both to the relationship, but also the patient psychologically. So what we want to do is try to bridge that fall to make it more manageable. So one example of that would be something like a warning shot. So in this example, you could say, I'm worried about how things are going currently, and that would move the patient down. And then we might say, I think we should refer to palliative care. And of course, the patient will still fall and will still hurt themselves, but not as severely as in the first example where there's that big drop. And so what we want to do ideally is not just have one warning shot, but use lots of little steps where we can guide the patient coming down to a point where they can step down to our knowledge level, or what our understanding is, without hurting themselves. And the key really is to find out the patient's understanding first, then to tell a story in stages that takes them from their understanding to yours. So in the end, the patient should be prepared to hear the news that you're going to tell them before you say it, ideally. And the number of steps will depend on the time you have, how pressured or charged the situation is. So it's not a one size fits all how many steps there will be, but it will depend. So the idea is if you had this scenario, then we can lower them down so that we're at the same expectations. So a conversation might go something like this. So this is a bit simplistic, but it's an example. So that same conversation that was that 3-line one where the patient hurt themselves might instead be, how are you feeling? And the patient might say, I've been feeling very unwell recently, despite the changes we've made to the medications. Can you remember why we thought you were feeling less well in the first place? We were uncertain, but we thought it might be because of my cancer. Yes, that is correct. I was worried that it might be because of your cancer. Can you remember what the oncologist said about your cancer? Yes, that it was something that could not be cured and would eventually kill me. And then we could follow up with, I'm worried that the changes we're seeing are because the cancer is getting worse. And as there is no way of us telling exactly how quickly things will change with the cancer, it's sometimes best to think about what the options might be if the cancer is progressing. there is a specialist team called the palliative care team who might be helpful for you to meet. They might be able to help in managing your symptoms and helping plan for the future if you are less well from your cancer. And then we give them a chance to respond, so similar to that spikes method where you've got that empathy part, and then following up with any questions they have, and then confirming and summarising. So are you happy for me to refer you to the palliative care team? And of course, as Ian was saying, not everyone will be at the top of this cliff. Sometimes there are people at the top of this cliff, and that can be the most difficult times to introduce it, and will require more of those steps, and possibly not even just in one consultation, but over several. And some people will be on a tiny little hill like this oak tree here, and in that case it might be much easier, and there might only be one step. So they might come in and say, it's my cancer making me less well, isn't it? I think things are changing. And in which case we can just say, yes, it is. Would you like to speak to palliative care? I think they could help. And the person can then make that step down without that injury. So it's going to be different depending on the patient and how well you know them as well. Does anyone want to ask anything about that as well? Because I'm a bit aware I just spieled a lot of information.
No, I think you're covering it really well. Ian's coming on with his picture, but I think, yeah, this is quite good.
Yeah, so I was just going to add in, I think sort of, that's obviously the ideal way. I think it's tricky when you either have an unexpected cancer diagnosis, and particularly I'm thinking about sort of, those people who pancreatic cancers, which kind of come rather out of the blue, and rapidly progress, or ovarian, and also just wondered sort of, patients who are in nursing homes. We'll often discover that somebody's quite unwell. Clearly, they're not going to be for active treatment, and we often will go down the best supportive route. But again, sometimes those conversations haven't occurred, and particularly with the involvement of the family. I'm just thinking sort of, particularly out of hours, sometimes you've done everything right, and then suddenly a kind of family member comes up from kind of from somewhere, and throws a cat among the pigeons.
Yes. So in those more difficult ones, I wonder whether this next one might be a way to tackle those. It's a slightly different way of doing it, where it's a more sudden, where you're making a more sudden suggestion compared to what the patient might be expecting, or the family. But yes, that's it. I'm very aware that what I'm saying is a very idealistic way of doing it, and often it is much more complicated from that, and there's a lot more unpicking. But it's, in the time we've got, it was a bit hard to kind of go through all the other scenarios, but I'm very aware it's idealistic. So you're very right, Ian. The last bit I wanted to talk about, and I'm just a bit wary of time, is the wish, worry and wonder way of talking about breaking bad news, which is sometimes helpful. And again, you can use a combination of these kind of spikes, narrative, wish, worry, wonder together. So the wish, worry, wonder is for wish, where you're kind of aligning yourself with what the patient understands. The worry is a truthful but sensitive way of saying the truth. And then the wonder is a subtle recommendation without saying what you feel in a more harsh way. So you might say something like, I wish I noticed you're much less well recently. I wish there was something we could do to fix it. And I wish it was something we could fix, like an infection. But I worry it's not, and that it's related to everything that's going on in the background, such as your cancer, COPD, or whatever it might be. And then you can follow up with I wonder if it would be worth referring to someone like the palliative care team to help support you with your symptoms and or plan for the future if things aren't improving, which is a much more simple thing to kind of remember, that wish, worry, wonder. And actually, I find myself, since I've learned this way of doing it, since someone explained it to me, using that kind of wish, worry, wonder quite a lot, actually. I think it's quite a nice way of introducing uncertainty, and the fact that you're being kind of empathetic about where we are and the fact that there's uncertainty with it, and that maybe it's like a more subtle, nicer way of recommending something than sometimes we might otherwise go about doing it. Has anyone heard of that before, the wish, worry, wonder?
Sounds very useful. I look forward to using that, actually.
Okay, so I think that's me. So I'm sorry, there were quite a few points to cover, but I hope I put it in a logical way. So we talked a bit about palliative care and its very brief history and why the services are a bit like they are at the
Yes,
moment. There's the current structures, so what's on offer to you and your patients, particularly around the community. We talked when and how to refer and the referrals that we would tend to accept, and then how to introduce the subject of palliative care and a referral to palliative care. Does anyone have any questions at all about any of that? I think Julie's got.
Yeah, and a clap as well. Hands clap. Yeah.
No.
Can I just ask, how do we go about referring patients to Priscilla Bacon Lodge for blood transfusions? Is that something that we can do?
Yeah, absolutely. So that's the first. Let me go back to it. So it's still on the referral form.
Right.
So
Okay.
if I go back, there we are. So if you have a look on here, you can tick a box for IV treatment, and that's blood transfusion, intravenous iron. And we would just ask that you put a bit of information in about why they're having it and why you feel PBL would be a better place for them to have it. It's a relatively common thing that we do. We have people in for blood transfusions or iron infusions so that they're not having to come up to the hospital.
And does that have to be coordinated via AOS, or can we do a group and save if the patient's got a low HB and symptomatic?
Yeah. So we would so what tends to happen is the referral comes in if the bloods have been done before, fabulous. But then we would, once they've had their initial iron infusion, for instance, our nurse consultant would tend to then arrange their next bloods, bring them in when they next feel they need an iron, the next dose of their iron infusion or blood transfusion or bisphosphonates. And then the day unit tends to then continue on with that management.
Okay, brilliant. Thank you.
Sally's also asked in the chat whether that's available at Tapping House also.
That I don't know. I'm ever so sorry. I should know that, but I don't.
Oh, not to worry, because we could find out and then relay it back.
Yeah, I can find out and I'll let you know. I'll email you, Rachel, if that's okay, and then maybe you can distribute the answer. Were there any other questions at all, or any other thoughts about, like, those methods of introducing the idea?
Sorry, it's me again.
Go on, Julie.
I was just going to say something that we've started doing at our surgery is more involvement from a generalist point of view and supporting patients earlier from diagnosis. So I think one of the big feedbacks that we were given from our patients is they get a diagnosis at the hospital, they then have their treatment and they flounder along, never really knowing where to go and where to get support. So we're trying to sort of improve that support and communication earlier on in the pathway. Yeah. So actually, by the time it comes to having the difficult conversations, there's already a relationship, which then makes that easier.
Yeah, I absolutely think that that's probably the biggest thing that you can do, isn't it? Is to be really honest with people from the beginning, build that relationship, and then, as you say, when it comes to having a conversation about that, you've noticed things have changed because that relationship has been built up. It's less of a drop, is it?
Yeah.
And often the patients have realised themselves, but it's helpful to have a friendly face who's also recognised it. And the other thing to say is that if you refer to us early, it might be, as I did that very poorly done orange blobs in the blue background, it might be that we see someone and then discharge them, but then at least do you know what I mean? They've got to know our service.
Yeah.
Often they'll build a bit of rapport with our service and they're aware that they can come back to the service, and it becomes less scary then if they've been to, say, the breathlessness group, or they've come in for infusions. Then the idea of Priscilla Bacon Lodge and the palliative care team is a less overwhelming thought, because it comes kind of a natural progression that they might see the doctor from there to see about their pain or something, and it becomes less of a scary big change.
Yeah.
That's a really good point, Jodie.
Can I just lob another one in, which kind of both for you, David, and also, if there's any feedback from our primary care colleagues on the call. The introduction a couple of years ago of the respect form, and sort of, you would expect to have made these conversations easier because somebody's already had a conversation. Is your experience, from your side, that it is helpful and aids these conversations, or hasn't made any difference? And for many any primary care colleagues on the call, if they've noticed any change and whether it's helped with the pathway.
So from my point of view, the respect document, I think, is a really, really good one. I think it's the idea that, so going away from just having a do not resuscitate form, I think was a really positive step, because as we all know, so when we're talking about escalations for someone deteriorating, CPR is really at the very end of what might happen, and having a reform where you have the idea of discussing what happens in an emergency. So typically what I will tend to speak to patients about when I first meet them, certainly, is to get an idea of the sort of treatments they would and wouldn't have. And as part of that, you can document it on the respect form. And the things I talk about are, would they want things like antibiotics if we felt something reversible was happening, reversible cause of decline was happening? If so, would they be happy to have drip forms of antibiotics? If so, would they be happy to have them in somewhere like Priscilla Bacon Lodge or go to the hospital? And then you can build up to that. And if you were very poorly and we felt things were deteriorating, the resuscitation discussion, as opposed to before when you just had a DNA CPR, it felt like going right in for the very big thing and it became a whole difficult conversation. Whereas with the respect, the idea is that it's talking about all the different things that they might want. And so the DNR kind of just becomes part of a bigger conversation, and it seems somehow to flow a lot easier, certainly from my perspective of having that respect form. And also the idea that you can have a respect form and people can say, yes, I would want to be for absolutely everything. If it's the first time talking about it, then that's sometimes that, that's absolutely fine. But then the form is less scary. Whereas if you're going straight for CPR again, that seems really, people can get the thought of, so if you've got a brain tumor, for instance, suddenly it's jumping to, why are we talking about my heart kind of thing. Whereas if you've got the respect form, you can talk about, well, sometimes, unfortunately, people can get less well from aspirations or seizures. In those circumstances, what would you like? And you've talked about those, and then it becomes natural to go on to, if you were very poorly from your cancer, would you want us to be doing things like resuscitation, and talking about preferred place of care? Sorry, that was a very waffly answer. Does that cover what you're asking?
That's useful. Okay, final point from Vicky, and then we're probably at time.
Not necessarily for me, but one of my colleagues, Sue, has got a good question, I think. I don't know, Sue, you're there?
You're going to put me on the spot.
I have, because
hello, David.
Escape, Sue.
I'm Sue, the Cancer Project Officer from the team, and also work with patient and public involvement. And we have held some training for some clinicians before, and I've worked in primary care. So I just wondered, is there any training that is on or that could be on for clinicians to go through something like this? Because I think it's, your slides were brilliant, and I think, a lot of it'd be good to get that out there. And obviously we've got this webinar, but is there enough training that that's around that anyone can attend to sort of,
So there is. There's various bits and pieces that go on, which again I can try and circulate through Rachel. There's a bite-sized teaching which goes out from Priscilla Bacon Lodge, and I'm not sure exactly who that is aimed at, but it's a wide group of community healthcare professionals. So that's one source that goes out. I'm trying increasingly to do more teaching with general practitioners and community workers about general palliative care. And there are various other training programs like Sage and Time, you might have heard of, which again help to do some of the more symptom-based communication and communication skills. So there's lots of little individual ones out there.
That's great. Wonderful, thank you.
That's okay.
Right. So thank you, David, for a fantastic presentation. And I think sort of it's always worthwhile aiming high. I think communication and the way we work with early cancer diagnosis through the spectrum to end of life care. There are always lessons to learn, and learning and ongoing issues are well worth exploring. You mentioned very usefully sort of last breath, sort of the patient with brain cancer and brain tumours. So I'd like to just let everybody know that our next webinar on the 9th of August is going to be CNS, and that'll be brain tumours, etc., and how that pathway goes. And also a plug, we mentioned patients with spinal cord compression, and that's going to be the topic of our September webinar. Those are our forthcoming webinars. So thank you very much. This is recorded, so people will be able to pick it up later online. And thank you very much for your talk.
No, thank you, and thank you for everyone for being so interactive. It makes a real difference.
Right.
Thank you, David.
All right, I'll see you guys in a bit. Bye bye.
Okay, bye.